Welcome to today's video where we'll be exploring ureteral duplication anomalies. This congenital condition affects the urinary system, and understanding its intricacies is crucial for effective diagnosis and management. Join us as we delve into the world of duplicated ureters, covering everything from its causes to potential treatments. The exact cause of ureteral duplication anomalies is not fully understood, but it's primarily believed to be a result of errors during embryonic development. Specifically, it involves abnormal splitting of the ureteric bud, a structure that eventually forms the ureter, early in gestation. Genetic factors are suspected to play a role, and in some cases, ureteral duplication can be associated with other congenital anomalies affecting the kidneys or other organ systems. Environmental factors during pregnancy may also contribute, though specific associations are still being investigated. In a normal urinary system, each kidney has a single ureter that transports urine to the bladder. With ureteral duplication, one kidney has two ureters. These duplicated ureters can drain into the bladder separately, or they can fuse before entering the bladder, creating a Y-shaped structure. The crucial aspect of the pathophysiology lies in how these duplicated ureters insert into the bladder. Ectopic insertions, where one ureter inserts outside the normal location in the bladder, perhaps into the urethra, vaginal in females, or vas deferens in males, can lead to vesicoreteral reflux, the backflow of urine from the bladder into the ureter and kidney, urinary incontinence, and increased risk of urinary tract infections. The degree of functional impairment depends on the completeness of the duplication, the presence of ectopic insertions, and the efficiency of urine drainage. Ureteral duplication anomalies are relatively common congenital abnormalities of the urinary tract. Studies estimate that they occur in approximately 0.8 to 1% of the population. While they can occur unilaterally on one side of the body or bilaterally on both sides, unilateral duplications are more frequent. The condition affects males and females relatively equally, but the presentation and complications may differ depending on gender, especially with ectopic ureteral insertions. Many individuals with ureteral duplication remain asymptomatic throughout their lives. However, when symptoms do occur, they can vary depending on the nature and location of the duplicated ureters. Common symptoms include recurrent urinary tract infections, especially in children. Urinary incontinence, particularly dribbling of urine between voiding, can also occur, especially in cases of ectopic ureteral insertion. Less common symptoms include abdominal or flank pain, and in severe cases, hydronephrosis, the swelling of a kidney due to urine buildup, can develop, potentially leading to kidney damage. Diagnosing ureteral duplication anomalies typically involves a combination of imaging studies and clinical evaluation. Ultrasound is often the initial screening tool, especially in children with recurrent UTIs. It can reveal hydronephrosis or suggest the presence of a duplicated collecting system. Avoiding cystoarthrogram or VCUG is used to detect vesicoreteral reflux. More detailed imaging techniques such as intravenous pyelogram as IVP, CT urogram, or MR urogram provide detailed anatomical information about the ureters and kidneys, helping to identify the location and nature of any duplications or ectopic insertions. Cystoscopy, where a small camera is inserted into the bladder, may be used to visualize the ureteral orifices directly. Ureteral duplication can be classified into several types based on the degree of duplication and the location of ureteral insertion. Complete duplication involves two entirely separate ureters draining one kidney, each with its own opening into the bladder or an ectopic location. Incomplete duplication, also known as a bifid ureter, occurs when the two ureters partially fuse before entering the bladder. Further classification can be based on the location of ectopic ureteral orifices, whether into the urethra, vagina, vas deferens, or other locations outside the normal bladder insertion point. Treatment and management of ureteral duplication anomalies depend on the presence and severity of symptoms, as well as the presence of complications such as vesicoreteral reflux or hydronephrosis. Asymptomatic individuals may require no treatment other than regular monitoring. For those with recurrent UTIs or incontinence, antibiotic prophylaxis may be prescribed. Surgical intervention is often necessary in cases of significant vesicoreteral reflux, ectopic ureteral insertion, or hydronephrosis. Surgical options include ureteral reimplantation, where the ureter is repositioned into the bladder at a more appropriate location, ureterostomy, where the two ureters are joined together into a single ureter before entering the bladder, or, in rare cases of a non-functioning kidney segment, partial nephrectomy, which is the removal of the affected portion of the kidney. Currently, there are no proven methods to directly prevent ureteral duplication anomalies, as they are primarily attributed to genetic and developmental factors during pregnancy. However, optimizing prenatal care, including avoiding exposure to teratogens and maintaining a healthy pregnancy, may help to minimize the risk of congenital anomalies in general. Genetic counseling may be considered for families with a history of urinary tract abnormalities. The prognosis for individuals with ureteral duplication anomalies is generally good, especially with early diagnosis and appropriate management. Many individuals remain asymptomatic throughout their lives, and those who require treatment often experience significant improvement in symptoms and reduced risk of complications. Recent research is focused on understanding the genetic basis of ureteral duplication to identify potential risk factors and improve diagnostic accuracy. Minimally invasive surgical techniques, such as laparoscopic and robotic-assisted surgery, are also being developed to reduce the invasiveness of surgical interventions and improve patient outcomes.